everyone. I hope you all had a refreshing tea break. We'll now proceed with the second half of reproductive medicine session that promises an equally engaging discussion. May I request the next panel of experts to please take their seats on the stage. Professor Fauzia Manu, Professor Saqib, Professor Muhammad Ikram, it is a reminder for the poster experts to please go to the poster arena at 12 p.m. for the assessment. I will now invite Dr. Safia Sultana Munir for her presentation. She is reproductive endocrinologist and IVF consultant. The topic of her presentation is the association of endometrial thickness in fresh and frozen blastocyst stage embryo transfer and its impact on conception rate.
Today my topic is the association of the endometrial thickness with the conception rate. We all know that in ART cycles, the successful implantation, it depends upon competent embryo as well as the receptive endometrium. Now there are various methods to determine the receptivity. Some of them, they are the use of the ultrasound with the volume, with the pattern, blood flow, or taking the fluid and doing the gene analysis. But none of these, they have been found to be a successful predictor for the outcome. But endometrial thickness by transvaginal ultrasound, it is taken as a non-invasive and surrogate marker for the receptivity of the endometrium. And large survey was carried out over the international IVF specialists, and in which they found that 41% they rely that endometrium should be at least 7 mm for the transfer of the embryos, and 27.7% they relied even thicker endometrium, and 8.3% denied that we ignore the endometrial thickness before the transfer. The clinical question is, with such fragmented consensus, what is the optimal threshold for maximizing the clinical pregnancy rate? So today's question is, what is the optimal threshold for the endometrial thickness to maximize the clinical pregnancy rate? For that, we aligned our study with an international registry data, that is the Fertility Society and the International Fertility Society reporting system, and there was at least 244 cases data, and we aligned our study with that. And in that study that was published in Fertility Sterility 2025, they said that is 9 mm is the critical threshold, that is an inflection point at which the maximum pregnancy that takes place, and below that the pregnancy rate falls steeply and linearly with each decrease in the thickness. So we divided our data into two groups. One was, and we studied it across both fresh as well as the frozen embryo transfer cycles. And we divided this data into endometrium of equal to 9 mm and below 9 mm. And the second group was those with endometrial thickness of more than 9 mm. This study was carried out Dr. Sajjad's Australian Concept Infertility Medical Center, and it is a retrospective cohort observation study. The total subjects were 292 autologous IVF cycles that included both fresh embryo transfers and the frozen embryo transfer cycle. And this study was carried out between July 2020 to July 2021. And the location I've already told you, the primary outcome was conception rate, clinical pregnancy rate, and the miscarriage rate. Clinical pregnancy rate, as Dr. Tayyab in the previous talk already said, that is at 10 weeks when fetal cardiac activity is present, we say it is a clinical pregnancy, and the conception rate is total pregnancy outcome including the miscarriage. So clinical pathway and for the study integrity and standardization we use the transvaginal ultrasound for thickness measuring, and in fresh cycle, this thickness was taken at the time of the triggering of the cycle. In frozen cycle, the cycle was usually prepared by the sequential use of estrogen progesterone alone or with DECA, that is plus minus agonist, and the measurement in the frozen thawed cycle that was taken at the end of the estrogen phase before starting the progesterone. And we use the adjustant confounders, maternal age, body mass index, parity, whether nullipara or multipara, what was the infertility diagnosis, the cause of the infertility diagnosis, what was the FSH dosage, and what was the number of the retrieved oversize and the number of the mature oversize retrieved as well as the transfers. These were the adjusted confounders. So statistical analysis, we applied tool SPSS version 27 for the complete data analysis, and man-Whitney test was applied for the continuous variables, chi-square test for categorical variables, and for the predictive modeling, we applied binary logistic regression to isolate the independent factors that may affect the clinical pregnancy rate, and the significance set up at the less than 0.05. So this is the first table that shows the demographic as well as the IVF characteristics of the population. We can see the population, that is the group 1, that included those who had the endometrial thickness of equal to 9 or less than 9, and N was equal to 115. And the EMT more than 9 mm, that number was 177. As we see, that is the age and BMI and the type of infertility and the cause of infertility, these factors, they matched in the two groups. And the most common factor, that was male factor, and followed by unexplained factor, that was the cause of infertility, and this was carried out. And of course, primary infertility was more dominant as compared to the secondary infertility, which were usually previous 1 or 2 miscarriages. And in the preparation, we use either, as already said, HRT or HRT with DECA, and the cycle type, that is suppression of the LH, that was carried out either by agonist and antagonist, and our antagonist cycles, they were dominated, and the fresh transfer that was carried in over 76 cycles, and the frozen transfers that was carried out 126 cycles. And when we see the other factors, that is M2 retrieved oocytes or blastocysts retrieved or number of the blastocysts, they usually matched in the two groups. So in our table 1, that is there is a statistical significant evidence of BMI was identified between the two groups. That is notably 20% of the EMT less than or equal to 9 mm cohort presented with the obesity compared to the 22% of the more than 9 mm. And there was also shifts in the normal and overweight distributors. Normal weight was 38.3% in those with a group 9 mm or less than 9, and 23.2% they had normal BMI in endometrial thickness of more than 9 mm. And when we see for the pregnancy outcome, total conception rate in those patients with an EMT of less than or equal to 9, that was about 41%, and in those with more than 9 mm, the pregnancy rate was 44.1%. And when we see for the miscarriage rate, that was 4% in less than 9 and 9% in that, and that means clinical pregnancy rate in less than 9 or equal to 9 EMT about 32.2%, and more than 9, 39%. So those patients who had more than 9 mm endometrium, they had more clinical pregnancy rates. The pregnancy rate data was, that was the endometrial thickness usually fall between the 8 and 12 mm. That is, beyond 12 mm, there were only 5 to 6 cases in our data, and below 8 mm, there were only 11 cases they were carried out. And in fresh cycle, usually the mean endometrial thickness was 10 to 12 mm, and in the frozen cycle, it was about 7.9 to 9.5 or 10 mm. So this is the bar graph. We can see that the total conception in those patients with the less than 9 mm, it was 35.7, and it increased in those with a more than 9 mm EMT. And when we see the clinical pregnancy, as I already said, it is 32.2% in less than 9 mm and 39% in those with EMT of more than 9 mm. When we applied the logistic regression for the predictors of the clinical, maternal age was a favorable predictor, that is 25.2. The younger age patients, they favored the higher clinical pregnancy rate. And similarly, the endometrial preparation method, those who received HRT plus agonist, they also favored the higher clinical pregnancy. Trend was about 14.6%. And in the cycle type, although integumenous cycle was more in number, but agonist cycle also favored the clinical pregnancy about 11.8%. So this is again repeat, that is in clinical pregnancy less than 9, that when we use HRT plus thin endometrium, is this cycle preparation that favored the clinical pregnancy as compared to the HRT alone. And in the case of the thicker endometrium, HRT alone that performed better for the clinical outcome. Cycle dynamics, again, that is agonist cycle, they favored the thinner endometrium. There was more pregnancies when the agonist cycle was used as compared to the antagonist cycle. Study cohort heavily favors frozen transfers that was performed in 74% of the cycles. This sets the stage for the analyzing the different impacts of the EMT on fresh versus the frozen embryos. As Dr. Sadia already has said, mostly some centers they are performing, and we are also emphasizing because of the supraphysiological levels of the hormone, that is the frozen cycle gives rise to the better outcome. So this is in the form of the bar chart. The blue one that tells us about that was in the fresh, and we can see there is a large difference in the fresh cycle. When the endometrium was less than 9 as compared to the more than 9, there was the quite significant increase in the clinical pregnancy outcome. But in the frozen, that didn't make much difference. This can be seen over here in the fresh pathway. There was almost 16.8 difference in the less than 9 endometrium clinical pregnancy outcome and the more than 9. That is, in the more than 9 mm, there was much 16.8 difference in the clinical pregnancy. As compared to the frozen cycles, there was only 3.8%. So the global alignment is that is optimal clinical pregnancy is achieved past the 9 mm threshold, and based on the 244 and 100,000 cases in embryo transfers of the SART course data, the live birth rate increases up to a strict 9 mm threshold before plateauing. But in our study, we also found that beyond 9 mm, there is increase in the live birth rate. And our maximum patients, they fall between the 9 am and 10 am. Outcome is in the Lahore study peaked in the highest category of more than 9 mm, yielding the pregnancy rate of 39 to 44%. And is there such a thing as too thick? In a study carried out by the Al-Toki, they suggested a decline in pregnancy rate at more than 14 mm. But the SART and Carter data, mega registry data refutes this, showing absolutely no decline in live birth, even at extreme thickness of the 18 mm. Okay, sir. So clinical conclusion is 3 pillars of the practice. That is, we should at least optimize the endometrial thickness up to 9 mm that maximizes the conception locally and globally aligned with the SART-Carter data. EMT remains a highly reliable, implacable surrogate marker for the endometrial receptivity. Actionable recommendations are for the patient presenting with stubbornly thin endometrium of less than 9, prescribe an HRT plus decapeptide protocol to mitigate the basal layer toxicity and rescue the conception rate. Thank you very much. These are the some references.
May I please request all the speakers to please adhere to the timelines. Thank you very much.
Dr. Rabia Mushtaq, she is FRCOG and member IRC Pakistan. She will be sharing with us the comparison of pre-implantation genetic screening test results between day 5 and day 6 embryo in ICSI.
Thank you so much, Sanya. So it is good to be in this audience of very senior IVF and reproductive medicine consultants. Last 10 years for IVF and fertility have been changing very rapidly. So we all started. So in 2015, when I started IVF journey, the time was of fresh transfers, and then we moved on to frozen transfer. Also, from day 3 transfer of morullas, we moved on to the blastocyst transfers. And I think part of that journey is actually culturing embryos for longer. So from day 3, we've moved to day 5. The question is that, is there any room for moving up to day 6? So the title of my study is Fate of Blastocyst After Day 5 in IVF and ICSI, and Need for Day 6 Blastocyst Culture Continuation. So extending the culture to day 6 is debated because the developmental delay makes us wary if there is going to be possible aneuploidy and reduction in the implantation risk. And therefore, when there are good embryos available, usually after day 5, the embryos are discarded at that point. So we decided at Genova IVF and Fertility Center to use the embryos which were destined to have PGT24 to answer this question about aneuploidy, first of all, and seeing if there is any reason that we should try to continue the culture to day 6. It is a retrospective study carried out at Genova IVF Center, Lahore. Duration was for 1 year, and we included 100 patients which were undergoing IVF ICSI as well as PGT24 chromosomes. There were total number of blastocysts from the patients that were, of these 100 patients were 544. Out of them, 403 blastocysts were from day 5, and there were 142 blastocysts which had cultured and grown up to day 6. Trophectoderm biopsy was performed on these embryos, and genetic analysis was carried out at iGenomics. So these embryos, trophectoderm biopsies, were taken and sent off to the Spanish company, which is iGenomics, with their centers available in different parts of the world. And the clinical outcome measure was a clinical pregnancy. Please be wary, it's a recent study, therefore we do not have live birth data completed yet. However, clinical pregnancy was defined as a pregnancy with fetal cardiac activity present at 7 weeks of gestation. So this included data from 51 FET cycles. If we look at the results, the very first question was that of the euploid embryos. We found that 67.74% of the embryos from day 5 were euploid, while at day 6, 62.68% were euploid. So if we look at it, the rate of euploidy is quite similar between day 5 and day 6 embryos, which actually supports our statement that we should culture embryos to day 6. There are comparable rates, and there's no significant increase in aneuploidy noted. The second question was pregnancy rates. So overall clinical pregnancy rate, which was again cardiac activity at 7 weeks gestation, overall was 49.02%. Out of them, for day 5 embryos, 53.66% was for day 5 embryos. And if we look at it, there is still a reduced rate noted at day 6 embryos, but still good enough to vouch for it that we should continue to culture, a rate of 30.67%. It is still meaningful to culture them up to day 6. My next slide is going to be controversial because it is actually going against the gist of what we have learned in IVF, that age matters. And I will explain it, how this has happened. So age-based result, I thought we should look at what happens with age groups. Our results were such that age under 35, we had 37.5% success rate, while age over 35, the success rate was 52%. And this was very puzzling for us. And we were thinking, how has that happened, that we are getting patients age over 35, the pregnancy rates are higher. And then we stratified it and see, okay, let's have a look. Is there an impact on how many are day 5 and how many are day 6? So, but the results remained the same. For day 5 embryos in age under 35, 42.11% was the pregnancy rate, while on day 6, only 20%, as compared to higher rates seen in age over 35. So this was a dilemma for us. And then what we did was that we went back to the drawing board, we went back to the notes of the patient and see how has that happened. And what we realized was that the patients age under 35, most of them who had opted for PGT24 were actually those patients who had history of recurrent IVF failures before or had recurrent miscarriage or other causes available, as a result of which the rates were lower. As compared to the patients age over 35, most of them were those who had carried out the testing with the fear that it can lead to aneuploidy can be increased with advancing age, as a result of which they had the risk factors were less for them, and they conceived more because other risk factors for IVF failure were less in that age group. So, day 6 embryos are not inferior when it comes to euploidy. They do have a lower implantation rate. However, it is still a viable option, and it is important, especially for the patients that have a limited number of embryos, that we culture them beyond day 5. So we should not discard them, and it has a comparable euploidy. It offers an additional pregnancy chance to these patients, and especially it is useful in patients over the age of 35. The other thing that I want to highlight is that it does look like for an IVF center, the success rates that I am quoting are quite high. But we have to bear in mind that these were the patients with euploid embryos that we were talking about. The pregnancy rates are higher because these are PGT results. If you ask me, these results should be even higher. We should be able to get 70 to 75% positive pregnancy test or clinical pregnancy rate when we already know that the embryo is normal. So I feel it's high, it's good, a cap in their feather. However, it still has a room to improve, and it should be still higher than this. Thank you.
Our next virtual presenter is Dr. Shehzad Rabi. She is consultant at North Middlesex University Hospital, London. The topic of her presentation is cesarean scar pregnancies as an emerging challenge.
Just from London. Thank you for inviting me to talk on cesarean scar ectopic pregnancy. So what is cesarean scar ectopic? It is an early pregnancy complication where the gestation sac is implanted in the niche, which is a scar defect with very poor healing. It has an increased risk of maternal morbidity and mortality in view of the complications that can occur if the diagnosis is delayed. How common is it? So the UK early pregnancy surveillance system conducted a study which showed an incidence of cesarean scar ectopic between 1 in 1800 to 1 in 2500 of all cesarean deliveries performed. Now, this study looked at 58 cases, and the estimated incidence is 1.5 per 10,000 per year, and the number of maternities involved were 390,361. One important statistic is that the risk is increased from 1 in 400 to 1 in 50 when the patient has 2 or more cesarean section. Of course, we all know that this increase is due to higher cesarean section rates. It also accounts for nearly about 6% of ectopic pregnancies in women with prior cesarean section. So this is just a slide showing the terminology for describing normally sighted and ectopic pregnancies. So when we say intrauterine pregnancy, it doesn't mean that it's a normal pregnancy because intrauterine pregnancy can include cervical ectopic, cesarean scar ectopic, and intramural ectopic. So when we talk about a normally sighted pregnancy, it's usually the one inside endometrial cavity, and we can say normally sighted early pregnancy or normally sighted live pregnancy. So this is just to clarify the terminology that we should be using. So in terms of classification of cesarean scar ectopic, there is the androgenic type, where we find the gestation sac growing towards the uterine cavity. And the exogenic type, which is type 2, the gestation sac of the pregnancy will be growing towards the bladder or abdominal cavity. It will go through the uterine wall and can protrude through the broad ligament as well. So, in terms of clinical picture or clinical presentation, the patient would have vaginal bleeding, mild abdominal pain. Sometimes the patient is completely asymptomatic, referred from antenatal clinic when they go for the dating scan. And in extreme cases, the patient will present with severe hemorrhage and shock following uterine rupture. So the gold standard for diagnosis, of course, is transvaginal ultrasound, whether it's combined or not with transabdominal scan. Every patient who presents with early pregnancy complications, whether it's bleeding or pain, and knowing that she had cesarean section in the past, we need to do transvaginal scan to be able to do full assessment of the uterus. So when we look at the ultrasound diagnosis criteria, the Society for Maternal Fetal Medicine criteria and RCOG Green Top guideline are similar. So we talk about empty uterine cavity and undercervix, a placenta or gestation sac or both embedded in the hysterotomy scar, a rounded or oval gestation sac filling the scar niche, a very thin or absent myometrial layer between the gestation sac and bladder, prominent or rich vascular pattern in the area of the cesarean scar. This is very important to diagnose cesarean scar ectopic. And sometimes we do find embryonic or fetal pole or yolk sac or both, with or without. If we look at the Green Top guideline, is exactly the same. And of course, all these criteria or description of ultrasound features are found in a woman who present with a positive pregnancy test. So here there are like examples of cesarean scar ectopic. So here we can see that the sac is embedded in the scar, and if we put the Dopplers, the vascularity will be mainly in the anterior part of the sac, and towards the cavity we don't have any vascularity. We have to be careful when it comes to when we are dealing with a retroverted uterus. We know for some reasons the cesarean scar healing is very poor in when the uterus is retroverted, and this is where this usually we find this is where a scar ectopic happens, because the scar ectopic happens because of poor healing of that scar. We need to look at, as I said earlier, at the vascularity, and we know that the Dopplers, like the higher is the Doppler, the like the risk of hemorrhage will be very high as well when it comes to management. So full assessment of the uterine cavity, locating that gestation sac in relation to the scar, and if we are suspecting a scar ectopic, then we put colors and see how much of vascularity we are identifying. So how do you manage cesarean scar ectopic? Yes, expectant is an option. However, it's not recommended. And the study did show that there was a 43% success rate. When you say 43% success rate, if the ectopic is diagnosed in late stage of first trimester or early second trimester, it becomes really difficult to manage it, especially if the patient opts to continue with the pregnancy. We usually offer termination of pregnancy if we diagnose a scar ectopic. But some patients, they opt to continue. These patients need to know and they need to be counseled properly about the risk of late miscarriage with increased risk of hemorrhage, and the risk of placenta accreta spectrum, which usually ends up with hysterectomy in these patients. Medical management is an option with methotrexate. However, systemic injection or systemic methotrexate is not recommended. We can use local injection or intragestational injection combined with surgery. And the effective treatment is, of course, surgical treatment with less complications. And surgical treatment will include aspiration and the ultrasound guidance, laparoscopic or vaginal excision, cervical sutures, and usually Shirodka sutures and balloon tamponade. And of course, in extreme cases where the bleeding is very heavy, we do uterine embolization. So from the Society of Maternal Fetal Medicine, this is a summary of recommendation. As I said, expectant management is not recommended. All the options, like surgical options, should be available for the patient. And if we opt for medical treatment, we usually inject it directly in the sac. And if a systemic methotrexate is used, it's not to be used alone. It's usually with combination of any other management options. And when, of course, the patient who chooses expectant management, as we mentioned before, there is a very high risk of hysterectomy, there is a very high risk of placenta accreta spectrum, and usually these patients are advised to have cesarean, elective cesarean between 37 and 35 weeks or to 36 weeks. Because of the risk of recurrence of cesarean scar ectopic, we usually advise a patient to have effective contraception and to avoid any pregnancy. In terms of complications, of course, hemorrhage is the most important complication. And as I mentioned before, usually it happens with expectant and medical management. Surgical management, especially if the scar ectopic is diagnosed at a very early stage, and usually below all cases with a gestational age of less than 10 weeks, managed surgically without any complications and without any issues. In our unit at North Middlesex Hospital, we stopped referring our scar ectopic to tertiary center, and if all of them are diagnosed by 9 weeks, and usually all what they need is suction aspiration and ultrasound guidance. Of course, if we think that there is increased vascularity, then we prepare a balloon tamponade or put cervical suture prophylactically, and sometimes we don't have to tie the suture at all. So we mentioned that one of the complications is placenta accreta spectrum if the patient continues with the pregnancy, and of course the risk of hysterectomy at delivery. The risk of uterine rupture has been reported as well, and recurrence of cesarean scar ectopic pregnancy varies from 5 to 40%. Some studies did report as high as 40%, and this is why we need to counsel the patient properly about the risk of recurrence and to try and avoid any future pregnancy, especially if they think that they've completed their family. So this is a case that we had in our unit. So there was a 36-year-old lady presented with the PV bleeding at 10 weeks. She never had any scans before in this pregnancy, and she had one cesarean. She's a para one with one previous cesarean section. So when she presented to early pregnancy unit, she had her ultrasound scan, transvaginal scan, and it showed normally sighted live pregnancy. Cardiac activity was present. She was reassured, but of course she was bleeding, but the bleeding wasn't very heavy, and she was sent home. This patient presented 2 days later with heavy bleeding, and she thought that she passed the sac, so she was scanned again, and she was found to have retained product. So no gestation sac, no fetal pole, but she had a good amount of retained product. And they suspected molar pregnancy as well. She had some features. And then, of course, they did beta SCG, which came back as 70,000. So the indication of surgical evacuation was there, and she was taken to theatre. She bled 1.2 liters. And she had blood transfusion, she had evacuation and the ultrasound guidance, and it was mentioned in the op notes that the uterine cavity was completely empty at the end of the procedure. This patient never stopped bleeding. She kept coming back to the unit with she was scanned, and this is what we could see. So here we can see the uterus. Here we can see the uterus, and on the lateral side, there was this mass, a 5 centimeter mass, very vascular, and we didn't know what it was. We were thinking this is persistent trophoblastic tissue because she had beta ICG of 70,000, and molar pregnancy was suspected. And then we were thinking it could be a fibroid, or it could be an accessory uterine cavity. So she was sent to a tertiary center. She was scanned, and she was found to have an ectopic, cesarean scar ectopic, which were herniated in the broad ligament. So now we don't know what happened. So basically it was missed in her first scan, of course, because the only images we could see were of a gestation sac with a fetal pole, but we didn't see any panoramic view or sagittal view of the uterus, and we couldn't see the scar So it was missed when she presented first time, and then when she went for the first evacuation, where she bled 1.2 liters, we don't know what happened. Maybe that tissue was pushed through the scar, and then ended up with a big collection of tissue outside the uterus. She had another evacuation in a tertiary center, but they put shortcut sutures, which stayed for 48 hours. And she had uterine embolization because she was bleeding profusely, but they conserved her uterus. So, in conclusion, increased incidence of cesarean cardiac ectopic has been recognized. It can be difficult to diagnose in a timely fashion, and therefore we need to be vigilant. And if a patient presents with bleeding or pain and she's known to have a previous cesarean section, we need to do an early diagnosis by scanning her, doing transvaginal scan, because if we diagnose cardiac ectopic early, we can treat at the right time and avoid all the complications. As we all know, optimal management remains uncertain, and we need to individualize management according to patient symptoms, ultrasound findings, and of course, patient's wishes. Thank you very much for listening, and I will be answering questions later on. Thank you.
Next up is Dr. Faza Fatma, gynecologist and consultant ART. She will be discussing with us the management options for missed miscarriage after frozen embryo transfer.
Assalamu alaikum and good afternoon. My name is Dr. Faza Fatma, and I'm working as an ART consultant and consultant gynecologist in Life Clinic Hameed Hospital. The topic that I'm going to discuss today is missed miscarriage after frozen embryo transfer and the choice of the management options, which is a difficult yet a crucial decision. As we are all well aware that missed abortion after any pregnancy, whether natural or whether through IVF, is a source of great distress for the couple. And as we all know that early miscarriage is defined as the loss of pregnancy before the 12th week, and it affects 10 to 20% of clinically recognized pregnancies. A positive pregnancy test after frozen embryo transfer in an IVF ICSI cycle is no doubt a source of immense joy for the couple and their family. Unfortunately, the incidence of having a missed abortion in IVF pregnancies is around 15%. So many patients who are undergoing treatment, they are from remote areas and they go for the management and care in their own area at different private medical setups of all sorts, which includes qualified people, and it also includes charlatans as well after a missed abortion. As this is a very emotional time, the decision making is very, very important because it can impact the chances of conception in the future for the couple. So generally, the management of missed miscarriage is divided into either expectant, medical, or surgical. These are some of the factors which lead to the miscarriage. That includes maternal age, that includes definitely the genetic factors, and embryo selection as well that impacts the prognosis of the pregnancy. Here are some of the factors which can lead to miscarriage as well as recurrent miscarriages as well, which includes the presence of antiphospholipid antibodies, antithyroid antibodies, as well as the sperm DNA damage. So coming to the different treatment strategies which are there for the management, the aim of our study was to find the incidence of conservative, medical, and surgical management of missed abortion in pregnancies as a result of frozen embryo transfer. Why this was carried out? Because this helped in clarifying to both the clinicians as well as the patients that which method can be chosen with the corresponding success and the complications. It is very important that the decision has to be tailored according to the specific needs of the specific patient. It was a retrospective study which was conducted at the Lahore Institute of Fertility and Endocrinology, and 50 patients were selected who had a missed miscarriage after frozen embryo transfer. Some exclusion criteria included termination of pregnancy due to personal reasons or ectopic pregnancies. The results showed that a total of 50 patients that were selected had a mean age of 35 years and an average infertility duration of 8 years. Amongst them, around 56% of the patients, they opted for the conservative management, 24% received medical treatment, and 20% underwent surgical procedures. So as you can see, that more than half of the patients have chosen the conservative management. It is very important that we understand that what exactly conservative management here means. As we are all well aware that after frozen embryo transfer, we give the patients hormone support. This hormone support is given in the form of oral as well as vaginal medication. Once we diagnose that the patient has a missed abortion, we stop that hormone support. Once the hormone support is stopped, that results in a sudden and a sharp decline in the blood hormone levels, especially progesterone. That results in an automatic withdrawal bleed, and therefore the patient avoids any unnecessary intervention. As we can see later on in the results as well, that more than 80% of the patients who opted for this method actually had a success. Below 20% of the patients had to go for an additional procedure in the form of medical termination or surgical termination. Most of the patients were able to bleed within a week of stopping the medication, and the remaining also bled within the 3 weeks of stopping the hormone support. As far as the medical treatment is concerned, it was opted by more patients as compared to the surgical management just because of the fear of the surgery. And the patients, however, who chose the medical management, as you can see over here, that they also had some complications. Please bear in mind that heavy bleeding over here does not really mean hemorrhage. It is just the patient's own perspective regarding the amount of blood that they had, and pain, of course, that was the cramping that they felt once the process of induction or process of miscarriage started. So amongst them, the patient who underwent surgical procedures, mostly these patients were those who either had a failed medical management, which were around 30% of the cases of the medical management, or these patients were those who just wanted to get the pregnancy cleared out as soon as possible because of the emotional aspect attached to it, and they did not want the pregnancy to carry on any longer and just wanted to get the process finished as soon as possible. As far as the outcomes were concerned, 72% of the patients, they regained their menstrual cycle within 1 month of the treatment, which was really good. So as soon as the patients, they started having regular cycles, their future plan for treatment and their future plan for conception was given to them. So we can see that most patients who had a missed abortion after frozen embryo transfer, they chose conservative management and had withdrawal bleed after the hormone support was stopped. And some patients, they opted for the medical and some opted for the surgical. And overall, medical management had a little bit more complications as compared to the other methods. Now, why this study was important? It is because, for example, if a patient had chosen for surgical management and they were living in a remote area where there was not optimal sterilization, or if the person who was doing was not qualified enough, that can definitely impact the future outcomes. If they go for an excessive curettage, that will definitely damage the endometrium, and in future pregnancies and in future embryo transfers as well, the issue of thin endometrium arises, or Asherman syndrome arises, and sometimes patients even catch vaginal infections or uterine infections. That can be a problem. So now this study has helped us that we can definitely, if a patient is counseled and discussed each and every option in detail, that they can easily go for the conservative management, in which once they stop their hormone support, there is a good chance that they will be able to bleed and be able to expel the products of conception on their own without any extra intervention. And if in case they need extra intervention, they should always go to a qualified person who is able to guide them properly that which method they should choose, which is something that many patients from remote areas, they are unable to access. Therefore, telecommunication has helped us to reach out to the patients and staying in touch with them with an empathetic attitude that can definitely help in the future outcomes. For future transfers, It is also important that they should lead a healthy lifestyle that includes stress reduction, a balanced diet, maintaining a healthy weight. It promotes the general well-being and it raises the chances of a successful pregnancy. It is further enhanced by psychological assistance such as counseling, which is essential for reducing anxiety and managing the emotional effects of loss. Thank you so much.
Our next presentation is by Dr. Komal Salim. She is Clinical Fellow at University Hospital of Wales. She will be joining us remotely due to the travel limitations and will be sharing with us the results of her audit on adherence to the RCOG standards for the manual vacuum aspiration in the management of incomplete miscarriage.
Assalamu alaikum and a very good afternoon. I'm Dr. Komal Salim, Clinical Fellow in Obstetrics and Gynecology at the University Hospital of Wales. Today, I'll be presenting our quality improvement project evaluating the ward-based manual vacuum aspiration for retained products of conception. Retained products of conception are a common presentation in early pregnancy care and are managed frequently using surgical evacuation under general anesthesia. While effective, this approach requires access to theatre, anesthetic support, and inpatient resources. It can also lead to delays in care and increased healthcare costs. In addition, exposure to general anesthesia may not always be necessary, particularly in clinically stable patients. Both NICE and the World Health Organization recommend manual vacuum aspiration as a safe and effective alternative that can be performed in an outpatient or ward-based setting under local anesthesia. This approach offers several advantages, including reduced recovery time, avoidance of general anesthesia, and improved patient flow. However, despite these recommendations, uptake of ward-based MVA in our unit was variable, and we observed inconsistencies in documentation and service delivery. Therefore, this project was undertaken to evaluate the safety, effectiveness, and the process quality of ward-based MVA in our setting. We conducted a retrospective service evaluation of 50 consecutive patients who underwent manual vacuum aspiration in a ward-based setting over a 15-month period from April 2024 to July 2025. Patients were selected based on clinical suitability, including the hemodynamic stability and ultrasound confirmation of retained products of conception. Data were collected from multiple sources, including the MVA logbook, electronic patient records, and follow-up reviews to ensure comprehensive outcome assessment. The primary outcome measured was procedural success, defined as complete evacuation without the need for further surgical intervention. Secondary outcomes including complication rates, specifically infection and bleeding, patient-reported pain scores using a 0 to 10 scale, and the quality of documentation within the MVA logbook. This allowed not only to assess clinical outcomes, but also to identify the system-level gaps in practice. Our findings demonstrated a high overall success rate of 94%, with 47 out of 50 procedures completed successfully without the need for further intervention. One patient required return to theatre for surgical evacuation. In terms of complications, one case experienced significant hemorrhage with an estimated blood loss of approximately 1 liter, requiring a blood transfusion. One patient developed infection which was managed with intravenous antibiotics over 24 hours. Overall, the complication rate was low and consistent with expected outcomes reported in the literature. Pain scores ranged from 0 to 8, with a mean of 4 out of 10. The majority of patients reported mild to moderate pain, indicating that the procedure was generally well tolerated under local anesthesia and oral analgesia. Importantly, ward-based MVA reduced the need for theatre utilization and allowed procedures to be performed in a timely manner, improving the patient flow within the unit. However, documentation within the MVA logbook was incomplete in several cases, particularly with regard to pain scores and procedural details, highlighting an important area for improvement. In conclusion, our findings demonstrate that ward-based manual vacuum aspiration is a safe and effective alternative to surgical management for retained products of conception in appropriately selected patients. The procedure is associated with a high success rate, low complication profile, and good patient tolerance. It also offers significant service level advantages, including reduced reliance on theatre resources and avoidance of general anesthesia. However, our evaluation identified areas for improvement, particularly in documentation and service standardization. As a result, we recommend the introduction of a standardized documentation template, regular staff training, and the establishment of a dedicated ward-based MBA service to ensure consistency. We also plan to re-audit within 6 to 12 months to assess the impact of these changes and ensure sustained improvement. Overall, ward-based MBA represents a resource-efficient and patient-centered approach to managing retained products of conception. Thank you very much.
We'll now have another virtual presentation by Dr. Muhammad Awais Khalid. He is an international training fellow at the UK. He would be discussing how subfertility impacts women psychologically.
Good afternoon, everyone. My name is Dr. Muhammad Awais Khalid. I'm a senior registrar at Arif Memorial Teaching Hospital, Lahore, and currently working as an international training fellow at Russell's Hall Hospital, Dudley, UK. Today, I will be presenting our study on the psychological impact of subfertility on women and its implications for counseling and clinician training. So, subfertility affects approximately 10 to 15% of couples, making it a common and clinically significant issue. In practice, fertility services tend to focus primarily on biomedical treatment such as ovulation induction and assisted reproductive techniques. However, the psychological consequences are often under-recognized, despite the emotional burden experienced by patients. Structured counseling is also not routinely integrated into fertility care, particularly in resource-limited settings. Therefore, our objectives were to assess the psychological effects of subfertility on women and to highlight implications for counseling and clinician training. So this was a cross-sectional study conducted at a tertiary obstetrics and gynecology unit. We included 80 women undergoing subfertility treatment over a 6-month period and used validated psychometric tools to assess anxiety, stress, and depression. In addition, demographic variables were analyzed to identify potential associations with psychological distress. If we first look at the data presented here, it highlights the overall psychological burden among women undergoing subfertility treatment. We can see that a substantial proportion of participants demonstrated elevated levels of psychological distress across domains such as depression, anxiety, and stress. This indicates that psychological morbidity is a common rather than an incidental finding in this population. To better understand this, we analyze the factors associated with this distress. If we first look at this graph, it shows a comparison of anxiety scores between the general population and the study group. We are comparing two components, state anxiety, which reflects current or situational anxiety, and trait anxiety, which reflects baseline anxiety tendency. We can see that for state anxiety, the study group has a noticeably higher score compared to the normal population. Similarly, for trait anxiety, the study group again demonstrated higher values than the normative group. So both state and trait anxiety are elevated in women undergoing subfertility treatment. This indicates that these women are experiencing not only increased situational stress, but also a higher overall psychological burden. This reinforces that anxiety in subfertility is persistent and clinically significant rather than being a temporary response. This section highlights the key associations identified in our analysis. Firstly, marital pressures were strongly linked with increased stress level, indicating an important relational influence. Secondly, educational levels significantly associated with distress, possibly reflecting differences in awareness or coping strategies. Interestingly, age and financial status were not significantly associated, suggesting that psychological distress is not purely socioeconomic. Societal expectations further amplify this burden, highlighting the cultural dimension. Together with the elevated anxiety scores, this suggests that psychological distress in subfertility is multifactorial and deeply influenced by social contexts. In conclusion, a significant proportion of women showed elevated anxiety and depressive symptoms. Over half of the women were screened positive. Anxiety scores were significantly higher than normative values, as demonstrated earlier, and psychological distress remains under-recognized in routine fertility services. This highlights a clear need for more holistic, patient-centered fertility services. These findings have important implications for clinical practice. We recommend integrating structured psychological screening and counseling into fertility services and enhancing clinician training to support a more holistic, patient-centered approach. Addressing the psychological impact of subfertility is essential for improving both patient well-being and overall treatment outcomes. Thank you.
I will now invite Dr. Samina Haq for this session's last presentation. She is an expert in infertility and laparoscopic surgery, and she would be elaborating us on circadian rhythm and fertility.
Bismillahirrahmanirrahim. Assalamu alaikum. Thank you, Professor Nazli and team, for inviting me for this very important talk on circadian rhythm and infertility. And I'm grateful that they have invited me to the third IRC RCOG Summit 2026. And I congratulate them for this summit's success. It's a successful, auspicious occasion with so many gynecologists from all over Pakistan. I was listening to Awais Khalid's talk, and he was talking about infertility percentage as 10 to 15. But according to recent statistics, Pakistan faces an infertility percentage of more than 22% in married couples. It includes primary and secondary infertility both. And choosing this topic was important because circadian rhythm have been thought about so seriously because you will agree that we have been confronted with infertility very much in the last decade. There is difficulty in conceiving, there are first trimester pregnancy losses, and there are a lot of developmental problems. In recent years, I've come across a lot of uterine abnormalities like bicornuate uteruses, septate uteruses, ovaries not formed. The percentage is very high in recent years. So does circadian rhythm affect the process of development? Does it affect the hormones? Does it affect, or does the nutrition affect our gynecological outcomes, obstetric outcomes? Let's have a look. How do I change the answer? Thank you. So daily circadian rhythms are governed by our master clock in the hypothalamic suprachiasmatic nucleus, which is SCN. These rhythms influence many bodily processes, including detoxification, metabolism, insulin secretion, fatty acid uptake, core body temperature regulation, and melatonin and cortisol secretion. So this circadian rhythm should be taken notice in fertility centers because this affects the body in a very crucial way. How does a circadian clock work? Now, every organ in the body is fitted with a clock, and it acts according to the master clock, which is in the suprachiasmatic nucleus, which is a bundle of neurons in the brain. So because I have very limited time, I'll just skip unimportant things. Daily circadian rhythms are governed by our master clock in the hypothalamic suprachiasmatic nucleus. The circadian rhythms influences many bodily processes like detoxification, metabolism, insulin secretion, fatty acid uptake, body temperature regulation, melatonin, and cortisol secretions. Circadian rhythm and nutrition. Now, this slide is a very important slide. As you can see, sorry, pointer. I think this is not working. Now, let's go to 6 a.m. At 6 a.m., the large intestine's clock is working. It is a wake-up call, and it releases the bowels. 8 a.m., the stomach clock starts, eat breakfast, go for a walk. 10 a.m., the spleen start working, food is converted into energy. 12 p.m., heart is at its highest. 2 p.m., small intestine is working, low energy, rest, and it is trying to digest your food. 4 p.m., the bladder, the constituents of the urine excreted at 4 p.m. is it releases waste, a lot of them. The bladder is very active, and the kidneys 6 p.m., the clock works more for them. Then pericardium, protection of the heart, 8 p.m. Winding down, endocrine balancing occurs at 10 p.m. Sleep, release bile, cellular repair, 12 a.m. And then deep sleep, when the person is sleeping, 2 a.m. the liver start detoxicating the body. And at 4 a.m. if you go out and you take deep breaths, the lungs clock starts working. So the body is working according to clocks. And if, for example, you order the children, the Z, Generation Z, it orders pizza at 2 a.m., then the liver wants to detoxify and the person is eating pizza then. So all the disruption occurs. Now, the concept of chrononutrition is very important because chrononutrition is nutrition according to the circadian rhythm of the body. Benefits: body weight management, improvement in blood glucose, insulin sensitivity, HbA1c reduction, cardiometabolic parameters improvement, manages hormone disruption. A healthy clock will give this, and an unhealthy, a disrupted clock will give poor sleep quality, depression, poor mental health, cardiovascular diseases, hypertension, fatty liver disease, insulin resistance or type 2 diabetes, impaired muscle function, cognitive functions will be disrupted. So if you are, according to a healthy clock, the routine, the daily routine is according to the clock, then you will be a healthy individual. Circadian rhythm and reproductive hormones. How the circadian clock regulate the reproductive hormones. Now, the sun, आपने देखा होगा पुराने ज़माने में वो सूरज को सजदे करते थे, तो actually the recent researchers have shown that the sun rays, when you go out after Fajr and you let those sun rays enter your eyes, then there is a pathway which is retinohypothalamic tract, which stimulates the suprachiasmatic nucleus. From there, melatonin is secreted. Melatonin is the main super hormone which controls all the reproductive hormones. You can see that the direct effect of melatonin on ovarian steroidogenesis, if melatonin is not secreted in proper amounts at proper times, you can have polycystic ovarian disease, fibroids, you can have endometriosis, everything, and these are all gene expressions which, this is all gene controlled, and it all depends on the circadian rhythm when you let the sun rays fall into your eyes early morning. वो जो सुबह की फजर के बाद जो वॉक होती थी, उसकी जो लाइट है वो जब रेटिना पे पड़ती है, retinal hypothalamic tract is stimulated and then everything goes into order. और अगर बच्चे 12 बजे तक 2 बजे तक सोए रहते हैं और फिर वो उठते हैं, there is no circadian rhythm and everything is disrupted. There are other hormonal disruptors also in the market, like all the cosmetics, all the scented candles, plastics, ये जो हमारे बाहर वो fumes होते हैं और atmospheric सारे environmental toxins जो हैं, they are also hormone disruptors. Face washes, body washes, toothpaste, everything is a hormone disruptor. So they have all the hormone disruptors, and plus if they do not adhere to the circadian rhythm, then everything goes haywire. This is a repetition of the previous slide. So everything is controlled by the suprachiasmatic nucleus by secreting melatonin and controlling all the hormones. Ovarian nutrient clock model, follicular phase. Now, there is a concept of chrononutrition, and if we are treating an infertile couple, in male and as well as in the female, you have to look after their diet. That is a chrononutrition. And in the follicular phase, the goals are follicular recruitment, oocyte growth, stable estrogen synthesis. So the key nutrients would be folic acid, vitamin B, iron, choline, and omega-3. Ovulatory phase, the goals are LH surge, follicle rupture, release of healthy oocyte, key nutrients, omega-3, zinc, magnesium, vitamin C. Luteal phase, the goals are progesterone, production, endometrial thickening, implantation support, and these are the key nutrients. Kitna time reh gaya? Khatam ho gaya? Chale. The time is over, so we should be advising patients, the couples, because if they adhere to circadian rhythm, it will improve the quality of the sperms, it will improve the quality of the oocyte, and it will definitely improve, slow down the ovarian aging. Thank you very much.
Thank you very much. I will now request the respected panel members to please conclude the session.
Dr. Fawzia Munim will comment on the first three speakers.
Thank you. First of all, congratulations, Dr. Nazli, for organizing, as always, an excellent conference and giving us the opportunity to participate. The first presentation was regarding endometrial thickness for embryo transfer, and all of us who are in IVF practice know that the final and the most crucial step of IVF treatment is the embryo transfer, and before that, the preparation of the endometrium for timing of that transfer, because patient is not interested in how many eggs we collect or how many embryos we make. They are interested in obviously a positive pregnancy test, and for that the implantation of embryo is obviously which will determine a successful outcome. So as our presenter said that they have a 9mm cutoff for the embryo transfer. So this is day and age of evidence-based practice, and ASHRAE guidelines already give us the range for the endometrial thickness, and the range recommended is 8 to 14 millimeters. The success rate for implantation significantly falls if the endometrium is less than 8 millimeters, and if it goes above 14, and in some studies it is 12 millimeters, then again the pregnancy rates fall. So the difference is significant in terms of live birth rate if the endometrial thickness protocol is not followed. So I would just like to highlight in terms of the presentation that, I mean, if a patient has 9 millimeters thickness and you will go for embryo transfer, you 10 millimeters पे आप cycle को cancel नहीं कर देंगे. You can follow that range because majority of patients will not fall at a strict one figure. So जो हमें range ASHRAE guidelines ने दी है, अगर हम उस range को follow करें तो then we are obviously able to cancel less cycles. Instead of just one figure follow करें तो हमें बार बार cycle को cancel करना पड़े, जो फिर patient के लिए एक stressful situation होती है. And the next presentation was about day 5 versus day 6 blastocyst. So जो day 5 blastocyst हैं, we again have evidence, and this is based on RCTs, which are randomized controlled trials and grade A evidence, कि जो live birth है after transfer of day 5 blastocyst is 44 to 57% versus 25 to 36% if a day 6 blastocyst is transferred. Because day 5 के जो blastocyst हैं वो fast growing and healthier होते हैं with thicker cell masses. But having said that, again, this has to be an individualized decision क्योंकि it really depends कि आपके पास embryos कितने हैं. If you have limited embryos और आपके पास enough day 5 embryos नहीं हैं, तो that doesn't mean कि आप day 6 embryos को discard कर देंगे, वो भी आप use कर सकते हैं. And then the third presentation was C-section pregnancy, जिनका scar pregnancy incidence उन्होंने UK में बताया 1 in 400 with 1 C-section and 1 in 50 after 2 C-sections. I think Pakistan में तो बहुत high होगा because हमारा cesarean section rate is much higher. जिस ज़माने में हम ट्रेन कर रहे थे यूके में तो अप टू 30% उनका सी सेक्शन रेट था और उसको भी वो बहुत क्रिटिकली देखते थे कि दिस शुड बी रिड्यूस्ड. अब गालिबन लास्ट ईयर 45% तक चला गया है, यूएस में 33% है और हमारे कुछ प्राइवेट हॉस्पिटल्स में, एंड दिस वाज अ स्टडी वी डिड एट वन टाइम, 70 to 90% है cesarean section rate. So I think हमारा C-section scar pregnancy rate भी high होगा और उसका main जो हमारे लिए objective होना चाहिए for the gynecological community कि उसको हम reduce करें, and all of us जिस भी setting में हम practice कर रहे हैं C-section rate की reduction की तरफ focus करें, because this is not the only complication which is related to repeated C-sections, placenta previa we had, so many other maternal morbidity and mortality relationship to this. So I was supposed to comment on first three. I think I'll pass on the mic now.
Bismillah Rahman Rahim. I am Dr. Muhammad Ikram, Head Department of Ops and Gynae Sheikh Zayed Hospital, Lahore. First of all, I will congratulate Dr. Professor Nazli regarding this IRC successful summit, and thank you very much for inviting me as a panelist in this very informative presentations. All the presentations were very well presented. I have a few comment or queries. First of all, the C-section scar pregnancies. One of the management that she described was cervical suture and insertion of balloon in tamponade. I was amazed why applying the cervical suture there. If you apply cervical suture, you are obstructing the cervix, and if there is bleeding, it will be inside, and it is blessing that if there is a bleeding, you can rescue to the next step. One comment was that. And regarding the Faza Fatma presentation, I was expecting there may be a difference in the management options in normal miscarriage and in frozen embryo transfer miscarriage, but surprisingly it is the same. So that was my one of the. And regarding the RCOG guidelines and manual vacuum aspiration, it is very important in, it is time consuming and theater timing and resources consuming. But the important thing is it shouldn't be done in a setup where the rescue services are not available. If you are the theater access as well as the backup blood is not available, it should be avoided. Otherwise, it is very important. Thank you very much.
I'm Dr. Saqib. लंच टाइम पे जो सिंपोजिया होते हैं तो शुरू में रूटीन ये थी कि डॉक्टर्स आए, पहले लंच सर्व हुआ, उसके बाद साइंटिफिक सेशन शुरू हो गया. तो एक आध टॉक सुन के डॉक्टर्स गायब होना शुरू हो गए. फिर ऑर्गेनाइजर्स ने सोचा कि लंच बाद में दिया जाए, पहले इनको टॉक सुनाई जाए, 4-5 टॉक्स दें और जो लंच है वो 5 बजे शाम को दिया जाए. फिर लोगों ने लेट आना शुरू कर दिया. अब आप इंटरनेशनल कॉन्फ्रेंसेस में जाएं तो जो साइंटिफिक फार्मास्यूटिकल कंपनीज़ के जो सिंपोजिया होते हैं, जिसको इंडस्ट्रियल सिंपोजिया कहते हैं, वो कहते हैं जी अंदर आके बैठें और वहाँ पे लंच बॉक्स सर्व करते हैं कि हुन किथे जाओगे. तो ये हल उन्होंने निकाला कि अंदर बैठ के लंच सर्व किया जाए। मैं जब सुबह यहाँ पे अर्ली मॉर्निंग आया तो मैंने नाजली से कहा कि इतनी जल्दी मेरा सेशन आपने रख लिया है, तो यहाँ तो कोई होगा ही नहीं। तो इन्होंने कहा नहीं, आपका सेशन जो है वो लंच के बाद है, तो वहाँ तो बहुत रौनक होएगी। तो आई थॉट के लेकिन इतनी रौनक में नहीं, लंच यहाँ सर्व करना चाहिए था। Thank you very much, Professor Nazli, for inviting me to come on this stage and talk about a few things. Cesarean section rate की बात फौजिया ने की, मैंने एक सिर्फ कमेंट इस पे दे दूं कि cesarean section rate जो जनरल पब्लिक है उसका परसेप्शन ये है कि डॉक्टर पैसे बनाने के लिए करता है। ये फिगर कोई मे बी 0.5% या उससे भी कम होगी। अगर आप 2-3 स्टेप्स ले लें तो आपका cesarean section rate कम हो जाएगा। नंबर 1, जो इंडक्शन ऑफ लेबर है, जेन्युइन इंडिकेशन जो है उसके ऊपर सिर्फ इंडक्शन ऑफ लेबर कीजिए, और वो सोशल रीजंस के आपने मुल्क से बाहर जाना है, आना है, तो उसमें या पेशेंट ने कहा कि जी मुझे इंड्यूस कर दें, ये आप अवॉइड करें तो सिजेरियन सेक्शन रेट आपका कम हो जाएगा। नंबर 2, ड्यूरिंग लेबर वो जो कंटिन्यूस आप फीटल मॉनिटरिंग शुरू कर देते हैं ना, हाई रिस्क में इस ओके, लेकिन हर पेशेंट में आपने सीटीजी लगा दिया और कर दिया और थोड़े से फीटल डिप हो गए हो सिजेरियन सेक्शन कर दें। तीसरा तरीका ये है कि फीटल स्कैल्प ब्लड सैम्पलिंग, वो है सही जो एविडेंस बेस्ड है कि फीटल डिस्ट्रेस डायग्नोसिस जो है वो सिर्फ एसिडोसिस से होगा। आप ड्यूरिंग लेबर फीटल स्कैल्प ब्लड सैम्पलिंग करें, जिसका पीएच लो है, जिसको एसिडोसिस डायग्नोज कर लिया, सिर्फ उसी का आप लेवल करें फीटल डिस्ट्रेस, हर एक को फीटल डिस्ट्रेस डायग्नोज ना करें। थैंक यू वेरी मच।
Finally, please, trial of labor to patients जिनका previous one C-section है. Lot of hospitals that we know of वो offer ही नहीं करते trial और previous one C-section के बाद success rate 60 to 70% है of normal delivery, और UK में previous 2 C-sections के बाद भी वो trial देते हैं patient को. So that is also an important factor to give that option to your patient if they are suitable for a trial.
Thank you very much to all our speakers for their insightful and valuable contributions. Your work truly reflects the advancing horizon of reproductive medicine. I would also like to thank our audience for their active participation, active listening and engagement, and our panelists for their thoughtful evaluation and comments. We will now have a 1-hour lunch break. After the lunch break, the fellows and members of RCOG who have to attend the presidential meeting are requested to please gather in Lecture Hall 1, and all rest of the participants are requested to please gather here again for Gynae Oncology session. Thank you very much.
Thank you very much. I just want to add for Dr. Saqib's comments, please, because I think it's a newer update for fetal scalp stimulation is part of it, but they are talking about in physiological CTG interpretation to reduce the need of doing FSC samples, because this was also thought to be contributory while clinicians were waiting for fetal blood scalp samples. They had hypoxic ischemic encephalopathy. So the review, which is each baby counts, I will invite from RCOG review. And in the recent NICE updates, it was actually not taken in. And being RCOG basic practical skill convener, this was the skill which we were not now training everyone to do. So just to be mindful of when to do it and newer indications to revise. So thank you very much.
Just to clarify what you just said, are they still doing fetal scalp sampling in the UK or not? So it's not done anymore. Yeah.